Welcome to the podcast of Hemisphere, the official journal of the European Hematology Association. Hemisphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Hello, and welcome to the Hemisphere podcast. My name is Charles de Bock, and I'm your host. A defining feature of many cases of acute myeloid leukemia is the presence of chromosomal rearrangements, where parts of two different genes become fused together. This results in the expression of a hybrid fusion protein, which often acts as the primary driver of the disease. Targeting these fusion proteins has historically been a major challenge, but why is that? Because unlike enzymes, which often have clear, druggable pockets, these fusion proteins tend to be transcriptional or epigenetic regulators, making them difficult to inhibit with conventional therapies. But recent breakthroughs are changing that dogma, and one of the most exciting advances recently is the development of menin inhibitors, a new class of targeted drugs that works particularly well in those cases of AML which have the KMT2A, or classically called MLL, rearranged leukemia. These inhibitors block the interaction between menin proteins and KMT2A fusion proteins and really disrupt that genetic program that drives the leukemia cell growth. But I guess the question is, can these menin inhibitors be useful beyond those cases with the classical KMT2A fusions? And could they be effective in other forms of AML that don't have that rearrangement? And so to find out more, I'm very pleased to be joined today by Professor Olaf Heidenreich from the Prinses Maxima Center for Pediatric Oncology Utrecht in the Netherlands, and Professor Michel Zwaan, also from the Prinses Maxima Center for Pediatric Oncology and the Erasmus Medical Center in Rotterdam, lead co-authors of the paper entitled "The MLL Menin Interaction is a Therapeutic Vulnerability in NUP98 Rearranged AML," that was also awarded the inaugural 2025 Hemisphere Award for the top cited biology article at the EHA Congress in Milan. So welcome to you both, and congratulations on your award for the paper. Spoiler alert, the first question, clearly, the title says it all, that indeed the MLL menin interaction is a therapeutic vulnerability in NUP98 rearranged AML. And so perhaps we should probably start with elaborating on what NUP98 rearranged AML is and why it's a particularly challenging form of acute myeloid leukemia.
Thank you for the question, Charles. I think I'll try to answer that one. A couple of years back, we basically investigated pediatric AMLs without clearly defined cytogenetic aberration. And in studying that, we basically came across that NUP98 rearranged AMLs were a very frequent event in pediatric AML. So pediatric AML in general is a fusion-driven disease. And we found out that this cryptic cytogenetic abnormalities, so you cannot detect them with regular cytogenetics, at least not the NUP98 NSD1. You can detect some other forms like NUP98 KDM5A, that they are actually quite frequent in pediatrics, 8 to 10% of pediatric AMLs. And the most striking feature was perhaps that they had very poor outcomes, especially in NUP98 NSD1. So suddenly a whole group of, let's say, unclassified genetic pediatric AML cases were classifiable as NUP98 rearranged, and we found multiple different translocation partners as well, so it's very promiscuous, just like KMT2A, although clearly the two big groups are NUP98 NSD1 and NUP98 KDM5A. And the latter is specifically or mostly found in acute megakaryoblast leukemia, also a very rare subtype of pediatric AML. So suddenly we had a whole new group of cytogenetic abnormalities in pediatric AML that were very characteristic, but also led to very poor outcomes. In terms of disease risk stratification, already a very important finding, because as of that moment, I think most groups have actually decided to classify this group of leukemias as poor risk, meaning that they get induction chemotherapy and quite often stem cell transplantation in first complete remission. So that is, I would say, the standard of care treatment given by most groups at the very moment.
So what, I guess, led you to try the menin inhibitors to begin with, knowing that they didn't have the classic KMT2A rearrangement?
Yeah, well, at least in that paper, we already also saw that there was HOX and MEIS upregulation. So we published that in the same paper. This was all happening at the time. I still worked in Rotterdam. And then in 2018, the Maxima came and I was talking to Olaf and we were sort of thinking of trying to find targets for these particular NUP rearranged cases, given their poor outcome. Of interest, maybe also they have a very high rate of FLT3 ITD mutations. I think we'll come to that in a moment as well.
Yes.
But that's the vast majority is also FLT3 ITD rearranged. And we were basically considering how we could improve their treatment options. And Olaf, maybe you can pick up why you sort of then jumped on the menin story or how this went.
Yeah, in contrast to Michel, who's a clinician, I'm a biologist. But nevertheless, I am sitting on the tumor board on a regular basis. The first thing I noticed was actually we do have a problem. There were a couple of, usually they come in clusters. We had a group of NUP98 rearranged patients who didn't do well. So that highlighted the problem to me. There was also, of course, a combination of opportunities here because the menin trial was already just opening at the Maxima. We were, and we are still, the only center here in Europe who can offer that. So patients who want to be treated with this compound need to travel to the Maxima for the moment. Then we did some sort of brainstorming, did some literature search, and we basically figured that these fusions are interacting with the MLL, and that this interaction was essential for them. And then I think it's just a relatively minor step. And again, the beauty of this menin-MLL interaction is you already referred to that. Here we do have a cleft, actually, which can be targeted by our medicinal chemists. And that makes it so unique. Usually you have wide and shallow interactions, which the medicinal chemists do not like. Anyway, so that was the starting point. And based on that, and also on the fact that in pilot work, we were already working on setting up ex vivo systems. And I was also previously in Newcastle and also setting up in vivo PDX systems. We had mouse strains available that are a bit difficult to come by, but which achieve very efficient engraftment. That basically set the framework. As I said, just a lucky combination of opportunities which allowed us to pursue this project.
Excellent. I like the fact that you also tweaked on the fact that HOXA9 and MEIS1 were kind of classic biomarkers, thinking as well, like, hang on, here are some downstream markers which suggest that there could be an MLL-menin interaction that bears that biomarker. One of the first results you actually present in the paper is this dose response for revumenib on the primary NUP98 rearranged AML patients using the ex vivo co-culture system, which you mentioned, Olaf. And there you co-culture with human bone marrow-derived mesenchymal stem cells. And if I can ask you, there'll be a lot of people who do work with AML, and to grow primary samples is quite challenging ex vivo. And so for those researchers out there who are listening who might want to replicate or even adapt this methodology, are there any technical insights that you can perhaps share on how you optimize that MSC feeder layer and managing that expansion, especially when you have dose response curves with two different culture systems in there? How do you distinguish the two?
There are a couple of different alternatives here. There are reports, and for instance, the group in Zurich, they're using a third immortalized MSC cell line. Others are using MS5, which is a murine mesenchymal cell line. We are using primary MSCs, which we isolate here from bone material, which we get from surgery. Each system has its advantages and disadvantages. The third cell line, of course, has the advantage of being very reproducible. The primary MSCs, if you need to change the batch, then you may have to adjust parameters again. But in general, our experience with primary MSCs is a very positive one. In general, it's the MSCs, the stromal MSCs of the bone marrow, they do form also the niches for the AML stem cells, or these leukemic stem cells. They're an essential part of that. And that was the basic idea to start with. Problem you already pointed at is that you now have two different cell systems. So you cannot simply have a metabolic readout like ATP consumption or NADPH production, because you cannot distinguish between the different cell types. So we used here something which was pioneered again by the group of Jean-Pierre Bourquin for ALL, where he segregates or separates these cells by the nuclear morphology. So we are using a stain called Cyquant. So it goes through the membrane, it stains the nucleus. And then the very first question is, how do we discriminate between cells with and without compromised membrane integrity? For that, there is a second stain which quenches the first one, but which cannot penetrate through intact membranes. So, I mean, first thing is we only see viable cells. or the nuclei of viable cells. That is a fluorescent approach, I should say. That's an image acquisition approach with a microscope. The second thing is that the nuclei of an MSCs, of mesenchymal stem cells, are quite different from leukemic cells. Leukemic cells, the nuclei are rather small. They have some odd shapes depending on the differentiation state. The nuclei of the MSCs are large. And then we simply use an algorithm which has been trained by us and which simply allows us to discriminate between those two. The advantage is that you get true cell numbers. So you don't get a metabolic readout, which sometimes comes with its own problems. Anybody who's ever tried to have cell cycle inhibitors, particularly CDK inhibitors, knows that you get there sometimes quite strange values. So you get true cell numbers, and you get true cell numbers for two different types of cells. So you get also information, how does this agent interact with cell A, the AML cell, or does it also do something to the niche or to a component of the niche? And that can be sometimes you want to have that, and sometimes you don't want to have that. In the case of the menin inhibitor, we did not want to have that. So we only wanted to see the AML effect. So we always have an internal control, which is quite positive. Regarding the medium, we are using a defined medium, which is serum-free, which contains a cytokine mix, which we have adapted or stolen, you can say, from the HSC people who are cultivating normal HSCs, which we applied here.
Adam Wilkinson's
yes,
lab.
Adam, for instance, is also part of that game, indeed.
Okay.
And we're also using two inhibitors mainly from the Savajot lab. And that is also quite interesting because these ones do inhibit myeloid differentiation. And the fact that we will later come back to that we do see differentiation with, for instance, menin inhibition. To see that, it means that these cells or that this process has to overcome a significant hurdle. But in the quintessence, that's the system, and that allows us to monitor cells over 2 to 3 weeks, something which we do need for epigenetic inhibitors because these drugs need time before they show their effect.
Absolutely. I think that's one of the challenges as well for ALL primary cells that, they rarely survive or let alone proliferate for an extended period of time ex vivo, and that's one of the kind of major bottlenecks to roll that out. So I was very interested to hear more about your co-culture system. I'm guessing, do you still add just a quiet segue, do you add the PVA as well in your mix as you do for Adam Wilkinson?
Not yet.
Or you don't have to?
Not yet, but that is clearly onto our to-do list.
Okay.
For the moment being, we're using a commercial medium with an undisclosed composition recipe, and obviously we're also working on our own recipes here for reasons I do not need to explain here.
Yes, of course, proprietary, right. So, you hinted at this differentiation, and if we can just probably stick on one of the technical aspects, one of the observations you did notice from the revumenib is the induced myelomonocytic differentiation. Were you actually, expecting that again? And for those researchers who are also listening and who might suspect differentiation rather than either like cytotoxicity, what advice can you give to really nail that differentiation?
For the MLLs or the MLL rearrangements or KMT2A rearrangements, there usually you have an M5 on M4 phenotype. That means it's a monocytic phenotype. These, if they enter differentiation, they go down the monocytic route. For the NUP98, that's a bit more heterogeneous, and Michel has published on that actually. There you have, and Michel, please correct me, but there we have basically, besides the M5, we have M4, we have M2, and also we have then the MKLs here. So there is a larger variety of potential outcomes in terms of differentiation. So we weren't quite sure. However, when we looked at that by flow, looking for differentiation markers, there we noticed the increase of classical myelomonocytic markers upon menin treatment. So at least for the majority of those cases, we see a clear shift towards monocytic differentiation, which of course comes with its own interest, because then the next question is, what do these guys do? And that is also something which we're currently looking into. What do these leukemic monocytes or leukemic descendants, if you wish, what do they do in the environment? But at least we can push them down to the monocytic lineage with this menin inhibition.
Michel, is anything you wanted to add with the differentiation?
No, just saying that I don't know, Olaf, if we really did enough work with the megakaryoblast subtype, the KDM5As, to
We haven't really touched that yet.
No, and I mean that might be different. So that these are the megakaryoblasttic subtypes of the KDM5A rearrangement. Most of the NUP98 NSD1s, I think, are myelomonocytic in origin as well. So there, I think it was sort of to be expected that they would behave like the KMT2A. So we weren't surprised with that, knowing, of course, already that revumenib-induced differentiation syndrome is the main sort of side effect, even leading to fatal cases sometimes. So that was the beginning, certainly very worrisome. And for pediatricians, also something we were not used to as much. In the certain areas of the world, you have acute promyelocytic leukemia in high frequencies. If you treat them, you have the same thing. The adults have the IDH mutated leukemias, and some of the IDH inhibitors also induce differentiation. But for pediatric oncology, I think, especially in the Nordic part of the world, where you don't have so much IPL, I think clinically there is a learning curve how to deal with differentiation syndrome. I remember the first patients we treated, we were sort of, I will always say, dancing around them to see if there was differentiation syndrome and when to stop the inhibitor or to start steroids. So for clinicians, I think there's definitely in the beginning a learning curve how to handle this. Although nowadays we often combine with chemotherapy, and then of course you effectively kill these cells, and the incidence of differentiation syndrome is approximately 0. So treating it together with chemo sort of overcomes this issue.
You mentioned, Michel, before as well that these NUP98 rearranged AMLs often do co-occur with FLT3 ITD mutations, which are known to carry an extremely poor prognosis. And your study shows that revumenib suppresses FLT3 and FLT3 ITD expression and synergizes with FLT3 inhibitors. Can you perhaps explain the rationale behind this combined therapeutic strategy, and from a technical perspective, why you actually did the sequential approach? So for listeners, again, if you read the paper, you'll notice that they did the menin inhibitor for 10 days, and then they did the FLT inhibitor for 3 days. So what was the rationale behind that strategy?
Yeah. I'll first go back to the history. In pediatric AML, we had quite a few publications saying that single FLT3 ITD mutated leukemia cases did worse. But that was in a time that we didn't pick up the probably primary driving genetic event, which is a translocation, such as NUP98 NSD1. So later on, we discovered that many of these single FLT3 ITD mutated leukemias are not single at all, but they have an underlying translocation that is probably the primary driver. And then we found this combination of NUP98 NSD1 with FLT3 ITD. So then, obviously, if you have two targets and you have two targeted inhibitors, it's sort of logical to combine them. But Olaf already found that the sort of expression was going down, both of the wild type as well as the ITD form of the FLT3 upon menin inhibition. And then Olaf, maybe you can pick up how you designed the laboratory experiment and took it from there.
Yeah, thank you, Michel, for the laurel, but I'm afraid this is not quite correct. I didn't see that. That was Milad Razuli who noticed that. The guy actually who did the work and who came to me with his observation.
He got the award, by the way. So not Olaf and myself, but Milad, just to make sure that everybody understands.
Yeah, where is Milad? Why are we not interviewing him anyway?
Well, we asked him, but unfortunately he wasn't available today. So that was just
he's bound by his experiments, apparently. The point is that he showed that the FLT3 showed a somewhat delayed response compared to MICE1 or other factors. And the reason for that is, again, when you dive into literature, is that FLT3 is a MICE1 target gene. So we hear a cascade of events where you have the menin MLL NUP98 interaction being disturbed. That reduces the MICE1 expression, and that then by itself affects FLT3 expression levels. And Milad could also then very nicely show that not unexpectedly, it's not only the wild type allele which is affected, but of course also the mutated one carrying the FLT3 ITD. Michel already pointed that out. I mean, I think some 80% or so of our NUP98s are FLT3 ITD positive. So that was a very nice and lovely observation, because it just tells you something like getting two for the price of one. But then there's, of course, still the question, does it make sense to further downregulate the FLT3 and the FLT3 ITD? And that's how we came up with this scheduled approach, that we first lowered the gene expression by, let's say, 70%, And one of the principles of enzyme inhibition in general is it's a concentration dependent. And it's not that if you have less enzyme with an inhibitor or less per target, that you inhibit with the same inhibitor concentration more enzyme. This is not the case. You will always inhibit, let's say, 50%. So if you reduce your total amount of protein with inhibitor 1 and then inhibit the other remaining 50 or 20% by another factor 2 or 3, the effect will be greater. Yeah, it's not the classical synergistic model, but it's simple enzyme genetics which play here into the game. And that's what we also observed, and which was also then basically led us to finally adopt this sequential approach, this scheduled approach.
If I can interrupt there, in terms of kind of counterintuitively, I would have almost suggested you would inhibit the FLT3 first, try and switch it off, and then have the menin inhibitor, because you're removing the target for the actual FLT3 inhibitor, of which, as you're probably aware, sometimes as a resistance mechanism, they'll just lower the level of the target for many drug targets. So It seemed almost counterintuitive to do it that way. Did you actually test it the other way just to see if it worked the other way? You did the FLT3 inhibitor first.
Actually, you got me on the wrong foot. I don't recall that. He probably tested it, but I don't recall. I don't think it was superior. Otherwise, we would have pursued that.
Okay.
However, one should also keep in mind is we had 1 or 2 of these patients also at the maxima, where that was the pre-revumenib time, when we treated actually patients with FLT3 ITD inhibitor, that the FLT3 ITD actually disappeared. And then a very small minor clone came up, which was already detectable by flow at the time of diagnosis. And possibly that was also one of the reasons why we intuitively went more for the FLT3 as a second target. But anyway, FLT3 ITD is not absolutely essential for maintaining the leukemia or for preventing the relapse. It's a secondary event. And for that reason, it's not a trunk mutation. It doesn't affect all the leukemic cells in a given patient.
So a strategy would almost be make sure you hit the truncal mutation first, irrespective, and then do the secondary in a way, because they're probably less reliant on those ones. Very interesting.
This is in the historical perspective where we originally were thinking of FLT3 mutated AMLs, only FLT3 ITD. Everybody was talking about hitting the FLT3 ITD, but I think now realizing that there's an underlying translocation, which actually probably is the primary driver of the leukemia. You know, this other one is only growth promoting, or let's say accelerating proliferation, and is probably sort of a later clonal event.
Yep. As you're probably aware, T-cell leukemias have the same notch mutations. It's actually one of the later events which help the cell cycle, which are great. Notch mutations are often a good prognostic factor because chemotherapy works on rapidly dividing cells, and that's actually good. So the ITD is also probably having a similar
Unfortunately, here it
role.
doesn't really help usually with the chemosensitivity, because the chemosensitivity is pretty poor, to be honest. Yeah.
If I can go to the next question, the FLT3 ITD is perhaps dispensable for these NUP98 rearranged AMLs, and you indeed show that treating a PDX with the NUP98 NSD1 with the concurrent FLT3 ITD mutation could actually be eradicated just using revumenib by itself, which was, well, I found it quite surprising because it's very rare that a single agent can do that, and especially in a PDX model. But you describe, well, I guess we can discuss that first, but then also in your discussion, you also describe the instances where menin inhibition might not be actually effective. And so what cases are those, and what implications might that have? So I'll open the floor.
Michel, you first.
Okay. Now, I mean, in the context of KMT2A, resistance mutations have been described, secondary resistance mutations, although a lot of these are subclonal. So it's also not yet a completely, let's say, eradicated story where everything is crystal clear. But clearly secondary resistance mutations occur. For instance, in a clinical trial, treated a patient who was primarily treated with revumenib, developed a resistance mutation, and then we tried another menin inhibitor, but that also didn't work out. So clearly there was even cross-resistance then in that particular situation. Although people in Boston, so Wallace Zwaan, he's really trying to figure out about these resistance mutations, and if certain mutations can be treated with another menin inhibitor and then still are sensitive. It sounds a little bit like the CML BCR-able story, right, where you develop resistance mutations and then switch to another inhibitor that may still be active in such a situation. So I think we will get some of that, or at least there will be publications on that. At the same time, the question is this really an issue with if you combine with chemotherapy, which, whenever we're going to take this to newly diagnosed AML patients, this will inevitably be combined with chemo. Nobody will use this as single agent, because clinically we've also seen that if you treat, that usually you lose response after a couple of cycles, right? So patients then relapse due to resistance mechanisms, all sorts of, might be mutations, might be other things. But if you combine with chemo, similar to the BCR-ABL story, the question is if these resistance mutations are clinically really important, because we know from the pH-positive ALL situations that, resistance mutations are rare compared to CML. So apparently it matters if you combine with chemo or not. So I think it can be sort of a mirror of that story in ALL clinically. So I think that part is what I can say about it.
Yeah, it's a tricky area. And yes, Michel is absolutely right. Most of these point mutations are subclonal. So it looks more like as if there is an initial process which confers resistance, and then it manifests itself with this genetic mutation. I mean, something which we also know from other examples. I know that people are working very hard on that, and there are also people like Florian Perner in Hanover also, or Hanna Uckelmann in Frankfurt who are working on that. One simply needs to wait and see. Even some ABC transporters were brought into the game here. So, and that is again, of course, a completely different mechanism.
Okay.
But I agree that currently what we're doing is we're using the menin inhibition as a bridging towards transplantation. Yeah, we are currently doing this in a relapse on a refractory setting. When it comes to the frontline, what I understand is that first results with the combination with chemotherapy are encouraging. However, one needs to keep in mind there are now more and more reports emerging that resistance against chemotherapy can go via a monocytic stage. And that is something which actually menin inhibition would promote. I think the jury is still out there how robust this approach will be. That's something which I cannot judge.
So in terms of broadening your findings, I mean, your study highlights a shared transcription. I'll start again. In terms of broadening your findings, your study highlights a shared transcriptional program between NUP98 rearranged, NPM1 mutated, and MLL rearranged AMLs, and particularly, as we mentioned before, this HOXA and MEIS1 expression. Do you think that measuring MEIS1 expression or performing this kind of comparative global gene expression analysis will help identify other patients beyond the NUP98 fusions who might also benefit menin inhibitors in the future? That is, do we only have to look at those kind of biomarkers to try menin inhibitors in the future for these patients?
I think it can be indicative. We tested that with the group of Jeff Clough from St. Jude's in the United States for the UBTF tandem duplications, another group of AMLs which are performing rather poorly. And there we had some tissue culture experiments similar to what we have discussed for the NUP98 and in vivo experiments. And again, that pointed towards susceptibility. And the starting point again was the HOXA and the MEIS1 expression there. Notably, in contrast to the MLL rearrangements or the KMT2A rearrangements, neither in the NUP98s nor in the UBTFs, the HOXA9 moves, or it hardly moves. The gene which does respond is the MEIS1, but not the HOXA. That is in contrast to the MLL rearrangements. But nevertheless, the signature is suggestive, is indicative, and we have now also more experiments being done also with AMLs of unknown drivers, which nevertheless have a MEIS1 HOXA signature. And again, they tend to respond, at least in our ex vivo culture. So I think in the long run, if that holds up, we probably can simply go by gene expression signatures and make this a predictive biomarker for menin response. There are a couple of more parameters to consider. For instance, you need certain epigenetic factors being present to modulate the responsiveness here. and that will also add to the picture. But the very first parameter, in my opinion, will be the MAIS1, the HOX-A, and possibly one or two other genes.
Yeah, and I think the interesting part is that for the UBTF, there has been this New England Journal of Medicine report of a clinical case that was treated and indeed was sensitive to menin inhibition. So there is now...
And even showed the mutation.
Yeah, no, I mean, so there is a clinical substrate now showing that this works, because of course there needs to be some sort of clinical validation. For the others, I think evidence is still very, very scarce that it will work clinically. So we are running a clinical trial where we are trying to have sort of an explorative cohort for all these other cases to get some experience. In that sense, every patient is one to understand if it works. So I think, but it's a little bit early days, but taken together would be really important, because it would mean that altogether maybe 40 or 50% of pediatric AML cases are actually potentially susceptible to menin inhibition, which is, quite a large proportion of our pediatric AMLs. And it would be a very sort of generic additional drug to our therapeutic armamentarium to hopefully increase the outcome and preventing relapse in the first round of treatment if this approach works.
Yeah. Kind of reminds me again of like the venetoclax for ALL, right? Which is like kind of the blockbuster drug in that context, where we can throw that in a lot of the time. And I mean, so you've hinted at this before, but what are the critical steps in translating these promising findings? You've hinted that 50% of pediatric AML patients could benefit from menin inhibition. How challenging is it going to try and convince others to change their clinical routine or their clinical practice and, think about resistance mechanisms? We've touched upon that already, but, we've got these fantastic results. What are those critical next steps in your mind?
So in pediatric AML, of course, we're sort of running behind the adult development as usual. Although there's a few things here that are really different from other development pathways. So first of all, revumenib in company-sponsored phase 1 and 2, they already in the beginning dropped the age to children. So in the phase 1, 8 children were treated, showing basically these mutations are not age-dependent and they work the same in a 30-year-old than in a 6-year-old. They dropped the age early in the phase 1 and generated data very early. So that is a very different development pathway, which, usually doesn't occur that children are recruited so early. So currently you can prescribe this in the US, and we are actually in the process of trying to secure access to revumenib in our frontline AML treatment, which the Maxima also happens to be the clinical trial sponsor of, which is called the CHIP AML study, which is a big consortium of 15 European countries. And we will probably try to add revumenib in that protocol as well in newly diagnosed patients. So that's a very, very fast development track for pediatric leukemia, which I think is absolutely fantastic that we now have been able to push this all the way through to newly diagnosed patients this quickly. It will hopefully start 2026, so it's not open yet. And then we have another menin inhibitor, ziftomenib, which is currently recruiting pediatric patients in the phase 1. And what I can disclose is that we had in the first phase 1 cohort that we tested, the first dose level 6 leukemias, 4 of which were NUP98. So it clearly shows that people are looking for new treatment opportunities for these NUPs. And then bleximenib is the third one that is in adults quite far developed, but they are just at the moment dropping the age to children. So we still have limited number of limited slots in clinical trials available at the moment. The only good thing is for people living in North America that they can get revumenib prescribed because it's already approved there. So, but not yet in Europe. So we are still dependent in Europe on the clinical trials to get enough slots. And honestly, we don't have enough slots for the medical need out there, with 40 or 50% of our patients potentially being able to benefit from a menin inhibitor. So that's the current situation clinically. And as I said, we try to not only recruit NUPs and UBTFs into the trial, but we also try to have a stratum for other rare subtypes that might be menin sensitive to build on the experience. And of course, we're looking at ALL. So there are discussions for our intervent protocol. In ALL, something like vast majority of the infant ALLs are KMT2A rearranged. So there it is also, and they have poor outcome. So there's also an important drug, although at the moment we're mainly focused on testing BLINA in that particular subset. But in the US, there is already a relapsed ALL infant protocol where revumenib is added, and that study is actively recruiting, but I haven't seen any results yet.
Excellent.
So that's more or less the pediatric landscape.
One last question I'd like to ask is the final paper, as presented, really follows the order of experiments. And so I guess during the course, and you've had a few hints at that, were there any surprising findings that when you went, whoa, here is an inflection point in the way that we're going to conduct this project? If you can think back, just to add a bit of colour to the story, that Michel came to you and said, look at this. This is unbelievable. We should really be changing tact.
This is one of the examples where the paper fairly represents the history. But I agree. Which is not the common case. I agree with you.
No. Because usually it's quite like, well, you start with one.
The two most interesting ones from my perspective were this note of the FLT3 inhibition.
Yep.
And preceding that, in general, the gene expression pattern which we observed and which were suggestive what different pathways to look at. And there were also some surprises. For instance, you had partners which are genes which were very much involved in RNA metabolism, and which then later turned out to be not really predictive. Something I would have put my hand into the fire for. That was not the case. So, but I think the gene expression pattern and the FLT3 ITD, that was something which at least I did not expect. But that might be also just the limit or the lack of my insight in that topic.
I mean, actually, I'm going to stop you there as well, because during the course of this conversation, I've called it MEIS1, you call it MICE1. Which is correct? I never know. Like, it seems to be wherever you go and a person speaks up, I go, okay, I'm going to change now. Is it MEIS1 or MICE1? What do we say? Or it's at the whim of the speaker?
Yeah, I think it's really up to the whim of the speaker, because, I mean, obviously the Dutch or the Germans would say mice. As in English, you probably depend on the region actually, more to the meese or the mice. And the Americans will clearly go for the meese, yeah.
Yep, I'm always confused, and I'm always like going, am I saying this really incorrect? I have imposter syndrome. So, okay, I'm going to continue to call it MEIS1. Everyone understands anyway. Okay.
Oh.
And one other segue, I'm always surprised at the 5' partners of a fusion protein. If you're trying to overexpress like an MLL or a KMT2A, just the general function would be, if the idea is to overexpress that at high levels as the truncal mutation, why would you not partner that up with a very strong housekeeping gene like GAPDH? Or it's a very kind of philosophical question. Why a NUP nuclear porin? Like, that seems so out of context. I don't have any thoughts on the role of the 5' partner, other than clearly they will bring in certain domains as well, which is quite classic for it. But I'm always surprised at the variety of the partners, which suggests it's not just overexpression. There must be other aspects to it, like in terms of dependency.
For the NUP98, you have these regions which are very poorly structured and which manage interactions. They are 5' located. Combining that with another functionality like the NSD1 methylase, that is clearly something which is a gain of function. You have other factors such as the RUNX1 ETO, where in that case the RUNX1 is the only gene which is expressed in the hematopoietic system, the partner is not. And again, you replace one functional domain by something which is doing almost the opposite by converting a modulator to a repressor. Again, that is 5'. However, with the MLLs, the situation is not so clear. Because when we again think of the infant AM, the most frequent one there is the MLL-AF4. And they actually do have a reciprocal product, AF4-MLL. And it's not quite clear what this protein is doing. And there's quite some evidence that it at least is required for initiating the disease. That might be something like a Kickstarter. Then later on, it might become dispensable. But at the beginning, it looks like as if it's required. So, I mean, this 5' is not always, it's not always true. I mean, in that case, particularly the MLL is a highly complex protein with multiple domains across the whole protein as you know probably better than me, the MLL is also the wild-type protein is cleaved into two portions by the TASPase, creating a physical separation of these domains. With the MLLs, I'm a bit more cautious with quite a few of the fusions, such as the NUPs or the particularly also the RUNX1 fusions. I mean, yes, there you usually have the RUNX1 at the 5' with the notable exception of the 1221, of course. There you have the ETV6 sitting there.
Yeah. I'm always surprised at how nature finds a way to deregulate these systems, and it's at every way possible that it can select for them. Well, I'd like to congratulate you both and Milat, the first author, on a wonderful paper for the inaugural prize. Thank you for your insightful discussions on the paper. For those of you who haven't read the paper, I would encourage you to navigate back to the 2023 editions and find this paper, because it's really quite astonishing that the results. It's profound, and I really like how it's now also meant that some of these findings are translated into the clinic, which is essentially why we're all here, right, to translate that bench to bedside story. So thank you both very much for taking the time to speak to us here at Hemisphere.
Thank you very much to you.
Thank you.
Great.
Bye-bye.
Thank you for listening to this episode of the Hemisphere podcast. All of Hemisphere's content is open access and can be found at www.hemispherejournal.com. We hope you will join us for future podcast episodes.